So the seventh tip I've got is to prescribe a season-specific rehabilitation program. And it makes a difference, you know, if they're pre-season versus in competition, the type of exercises you can give that athlete vary. So you need to remember that if it's in season, often you can only do what I call damage control, because the question is, can that athlete actually rest? Or do they have commitments to their team, for example, that they're unable to specifically rest? And so that will definitely change how you prescribe the rehabilitation program for that individual. And Ebony Rio did some work on looking at isometrics in season, and they found that isometrics are easy to do. They're not too high a load, and they have a very strong analgesic effect, and they certainly seem to be beneficial to keep an athlete going during in-season. I often think it's very hard to optimally rehabilitate during season, and so sometimes you just need to keep the athlete as injury-free as possible and to keep them going, so that you can then make a far more aggressive rehabilitation program post-season. And all of these pictures again are on the Groovi Physio software program, which you can access on that grooviphysiosoftware.com. And that is the Australian site, which will be effective for Asia and that region of the world. So now point 8 is you need to prescribe a clinically relevant rehabilitation program. Clinically relevant for the athlete in front of you, but also clinically relevant for the stage of the injury and the severity of the injury. So the entry point of rehabilitation for the person in front of you is individual specific, obviously depending on what we've just described, stage, severity, and type of sport. But initially, obviously, we're going to look at pain management and protection, moving all the way through flexibility, and regaining joint range, motor control, strength, duration, coordination, proprioception, back into full functional rehabilitation. And we use, these are actually the Groovi SI belts, which we use very successfully to improve force closure and improve load transfer at the lumbar pelvic region, which is going to be very effective in reducing things such as dynamic valgus, lateral shift, and improving the patient's ability to activate their core. So these type of supports do not switch off muscle activity, but actually increase the optimal activity by increasing force closure across those specific areas. So I thought I'd subdivide the rehabilitation a little bit into early, intermediate, and late. And it's again very variable because the sports and severities are so variable. But your early phases would be approximately days up to day 4 to 6, so from day 0 to day 6. And you're basically looking at trying to control pain and swelling and reduce the inflammation. So inflammatory control, pain relief, controlling pain and swelling. You might want to use a protective element I'll show you now. You might want to bring in your isometrics to help get that analgesic effect. And you might want to start some motor control, stabilizing exercises. So activating your core, maybe getting inner range, vastus medialis obliquus around the knee, maybe activating your deep gluteal system around the hip, or maybe starting to activate your posterior rotator cuff. So some small movements to start to get control. So I'll just put up some slides from the Groovi software just to show you some different options for that early phase. So we can use an ice pack, obviously, in the early phases. You're protecting the region. You might have crunches. Sometimes we give the patients little spiky balls so they can do their own sort of soft tissue release. This lady here is working on her tensor fascial lata region. We might do some protective loading exercises off a chair. Another protective is a Groovi elbow cuff we use for tennis elbow. We might be wanting to do active assisted shoulder movement if they are, for example, post-op. And we might be concerned about their diaphragm and their breathing mechanics, and we want to improve their breathing control. This is a very nice exercise for early phase for activating the posterior rotator cuff. And often we'll start that without a weight. So these give you a few ideas as well. I call this the modified 90-90, which is very nice, basically to stretch the posterior capsule of the hip. So it's kind of the sleeper stretch of the hip. So very, very similar to the one that you do at the shoulder. Now, this is a very nice piriformis stretch. Here we're getting an isometric activity to activate the gluteal muscles to try and improve that stability around the hip. We don't do the clam exercise anymore, which is rotation, because it tends to compress the glute med tendon onto the attachment of the superior trochanter. So we prefer to do a shin lift. So we avoid the rotation movement in the early phases, and we bring in an abduction movement or a shin lift, which will bring in the abductors without causing the rotation issue. So from here, we move on to the intermediate phase. And that would sort of last anything between day 5 to week 8 to 10. So again, variable because of the type of sport that you might be dealing with. But our sort of rehab here will be often unloaded and non-functional. So it's not getting them back into sport-specific work at that stage. So we'll use neuroplasticity. So neuroplastic training is where you use things such as mirrors and feedback, visual input, and get the patient to, or the athlete, to concentrate on the exercise, because that's been shown to have positive brain changes at the motor cortex, and we get increased firing at the motor cortex, which seems to give a very positive effect to improving your training. Again, I want balance between strength and flexibility. Again, each athlete will be different, but you'll find the balance for each person prescriptively for stretching and strength. And that's why I do have a concern with sort of team warm-ups where everybody does the same stretches and the same strengths exercises. You know, it should be prescriptive. A hypermobile athlete needs more strength and motor control, whereas a very stiff athlete might need more flexibility work. So it should be individual specific. So whereas we did isometric work in the early phases, we can now move on to different isotonic exercises or isokinetic exercises and use resistance such as elastic bands, free weights, gravity, machines. So there's quite a lot of different ways you can increase loading. And we want to look at coordination and balance, which will all sort of fit in under proprioceptive type exercises. So I thought I'd put a few exercises together. And again, this is off the Groovi Physio software app. And so what I've looked at here is I'm trying to rehabilitate an athlete that's got a hamstring tendinopathy at the origin of the hamstring. And so we want to activate the hamstring, but usually what causes the hamstring tendinopathy is hip flexion. So things such as deadlifts, and any sort of flexion or maybe too much lunging. So you can't give them exercises in the intermediate phase that would bring in too much flexion of the hip. So here what we're doing is bringing in, using hip extension with bridging with the weight. I've got like almost like an inclined row here. So I've reduced the hip flexion, and this is lovely to get core and external and internal oblique activation. Obviously bringing in my hip abduction, external rotation, and I can go into extension without flexing the hip. Using my shin lift again, but with resistance, or doing the fire hydrant exercise, which is very challenging and a great exercise to activate your neuroplasticity. Some studies have been done on this, and it's a very goal-directed specific activation of glute max. So give those type of exercises a go in the intermediate phase. And then we move on to the late phase, which is anything from day 21 of the rehabilitation to sort of 6 to 12 months post, again, depending on the severity of the injury and the type of injury that it was. So we want to now try and get the athlete back to the sport-specific activities. And this is where, as the practitioner, understanding the sport demands is essential to help you manage how you're going to bring this person back into sort of pre-injury and back into their full sport. So we're going to be looking at using our biomechanical loading exercises, look at agility and speed, power. We want to functionally return them to sport, and to do that, we need to look at the surfaces of the sport, for example, and we need to replicate the fatigue of competition so that the training has to match up to the fatigue of a competition level and not just be in your rooms. So here's some more increase in load exercises to give you some examples. So we've got the bird dog here on the left, which brings in, with elastic tubing, some really nice proprioception and control and load. Here we've got a Bulgarian type squat, and often just by putting one weight in one hand, you will really activate the opposite hip. I call the one on the left here the step up a mandala, which is a lovely coordination type exercise that brings in a lot of different groups. And then of course we've got the side plank here. Late phase, you might want to increase the challenge by creating an unstable surface, which brings in more balance and neuromuscular control. And often what I'll do is I'll if the athlete isn't in a specific gym, I'll give them one weapon or one apparatus that they need to work with at home. And you can use really one piece of equipment to get an awful lot of loading and get that athlete back closer to competition level. So some of the treatment principles and exercise principles when you are prescribing a program is try and for certainly in that injury, in that early and intermediate phase, you don't want to overwhelm the athlete, and often they're still doing a lot of rehab and cardiovascular training that is specific to their sport. So if they've got a shoulder injury, they're still going to be cycling, or maybe they'll be swimming and just kicking on the pool, but they'll be still spending a lot of time trying to keep that strength up. So try and limit your exercises to 4 or 6 exercises daily. They take about 20 minutes to complete, to try and improve the adherence or the compliancy from the athlete. If you're dealing with a tendinopathy, so I'm trying to give an example here of a lower limb tendinopathy, avoid compressive or tensile loading, because that will tend to overload those recurring tendons. So I gave you the example of avoiding the clam exercise, because that will give you too much compression of the glute med tendon as it inserts. Let's go to the one at the end here. Often the athlete says to you, so what can I do and what can't I do? And that's often I say to them, you can do anything you want, provided there's no pain more than a 4 out of 10 during your exercises, and so long as you're not worse up to 24 hours after you've done those exercises. So pain more than 4 out of 10 and pain increased over 24 hours both imply to you that you have overloaded that area. So that doesn't mean that the exercise was bad for that athlete. It just means that maybe the load was too much at that time, or maybe you've just done too many reps or sets, or maybe you just need to drop that exercise for a while and revisit it once the patient has strengthened a bit more effectively. So no more than 4 out of 10 pain, no worse at 24 hours, unless they are doing a functional loading exercise. So if your patient's lying on their side and doing a shin lift, the rule I've just given you applies. But if the patient is doing a step down activity or a lunging activity or a squatting activity, because that is a biomechanical loading exercise, there should be no change in pain. So 0 out of 10, or certainly no worse than their resting level during that functional loading exercise. Because if they do get pain, that implies that they're biomechanically, they're causing a compression on that area. So if someone says to me, when I walk 11 kilometers, I get medial knee pain, how much can I now do? I say, you can do whatever you want, provided you're not sore during the walk or after the walk over 24 hours. So if you get pain during the walk, that implies that you're causing some sort of mechanical or biomechanical overload on the medial side of their knee. So these are really helpful principles, because this way, you, instead of saying do this exercise and don't do that exercise, use pain as a friend and as a positive help, so that it can guide us positively on what the athlete can do. And by using this sort of principle, they become less fearful of pain and less reticent of it, and they more welcome it because it's giving them valuable information on their rehabilitation. So we used to do a lot of eccentric training, but truthfully, current, more recent research is more promoting heavy, slow resistance. So what we want to do is start them by getting endurance. And for that, we might do 3 sets of 15 reps. But as we increase their strength, so we get strength endurance to hypertrophy to maximal strength and up to power. So as we want to strengthen the patient, we increase the weight, but we decrease the reps. So you might end up with 3 sets of 15 to 3 reps, for example. It doesn't even have to be 8 reps, with approximately 30-second rest or a minute rest between sets. And when you do a loading program like this, then you would tell the patient to only activate or do these exercises every second day or so 3 or 4 times a week, so that you allow the tendon and muscle to recover and therefore hypertrophy. So exercises like a one-legged squat, you could start loading with heavier and heavier weights. And the heavier the weight, the less the reps. So the sets stay the same, but the reps decrease. And so we're building into a program of heavy, slow resistance. And often we tell patients to do 10 to 12 reps with three sets of 10 to 12 reps with a 30-second rest. I just want to show you, if we look at repetitions of an exercise, if you get the patient to do 15 reps per set, you can see here how it falls into an endurance type category. If you get the athlete to do 3 to 5 reps of a high weight, then you're starting to get strength and power. But if you sort of work on this sort of 10 to 12 reps, you're actually neither strengthening for power or for endurance. So it doesn't really specifically condition any particular component of muscle performance. And so it's far less valuable for you. So rather work the athlete with high reps for endurance or low reps with a higher weight for strength and power.